Greetings from Advanced Fertility. Today we are going to discuss a very important topic, polycystic ovarian syndrome. Now let us see what is polycystic ovaries and how we can treat it. So polycystic ovaries is a common word, and we all know that probably it is because of excess of androgens, which is the male hormone, excess of insulin, and probably it is genetic, it could be inflammatory, or it could be because of lifestyle factors. The insulin resistance that is inherent in polycystic ovarian syndrome leads to excess insulin, excess androgen, and androgenic symptom and more visceral fat, leading to worsening of insulin resistance and worsening of PCOS. So androgenic symptoms are something like the male symptoms like, hair on the face, acne, and along with it, you have the various other symptoms which we will come to right now. So it could be excessive body hair growth, it could be problems with your weight, it could be irregular periods, it could be acne, it could be mood changes, it could be infertility. These are how polycystic ovarian syndrome present. Now, 10% of women of childbearing age are estimated to have polycystic ovarian syndrome, and less than 50% of them are properly diagnosed. So, a lot needs to be done in this field. And this is the world map, and we see India as the blue area, and there is the severe metabolic syndrome. And polycystic ovaries is associated with metabolic syndrome, which means it could lead to obesity, diabetes, acanthosis nigricans, which is a skin problem. So this is very much common in the Southeast Asia, and polycystic ovarian syndrome presents in different form in different parts of the globe. So the basic diagnosis initially used to be something we call the Rotterdam criteria, means either you have irregular periods, late periods, or you have excess androgen symptoms like balding, facial hair, pimples or acne, or you have the ultrasonic picture of polycystic ovaries. So if you have any two of these three, you fit it into the polycystic ovarian syndrome. Now, this was carrying on till the last decade, till very recently, till 2018. And then in 2018, there was this international evidence-based guideline where all over the world, all the major bodies like the American Society, the Australian Society, the European Society, the Center for PCOS Research, they all got together, and then they came to this diagnosis that if you have irregular cycle and if you have acne or hair on your face, that is hyperandrogenism, your diagnosis is established of PCOS. But if you do not have acne or hair, and if you have your blood test which is showing increased testosterone, then also you fall into that criteria. But if you either have just the irregular period or just the increased evidence of testosterone, then you need to do an ultrasound which should show polycystic ovarian syndrome, and then you come under this diagnosis. Of course, there are many other causes of irregular periods like hypothyroidism, hyperprolactinemia, Cushing syndrome, adrenal syndrome, hypogonadotrophic hypogonadism. So all these things should be ruled out when we come to the diagnosis of PCOS. So when we come to irregular periods, different age groups have different definition of age groups. But generally, if it is less than 21 days or more than 35 days or less than 8 cycles in a year, it will come under the diagnosis of irregular menstrual cycles. And then what about the ultrasonic picture of PCOS with the multiple cyst that is seen on ultrasound? And usually it is not needed for young girls. It is only when you are in an adult age group. It is done preferably with a transvaginal probe. And in the latest article which we are discussing, more than 20 follicle numbers per ovary was discussed. However, in the Indian context, sometimes we even take up to 10 to 15 follicles in each ovary, and the volume of each ovary should be more than 10 milliliter. And transabdominal ultrasound usually is not enough for the diagnosis of PCOS. So another very, popular blood test, which is the anti-Mullerian hormone, it gives an indication, but it is not diagnostic. So usually the normal levels are 1, 2, and anything the PCOS lady do have higher AMH levels around 4 or 5 nanograms per ml, but it cannot be used for the diagnosis. So then clinical hyperandrogenism is something like acne, which is seen in this girl's face. It could also be less hair, a frontal paucity of hair. You have to have acne, alopecia, which is less hair, or hirsutism, which is increased hair over your face, in and around your chest, in your abdomen. So all these things, there are various clinical criteria of diagnosing them, and they come under the symptoms of clinical hyperandrogenism. Sometimes you cannot diagnose as the clinical hyperandrogenism. Then you need to do blood test. You may suspect, and then you need to do either free testosterone or free androgen index or bioavailable testosterone. DHEA and androstenedione, these are not very reliable tests. Sometimes increased testosterone can be found with malignancies, and we must be careful when we see high levels of these hormones. So another thing, when you are, working in an international setup and you see couples and women of different ethnic origin, Southeast Asia, that is Indian, Pakistani, Bangladeshi, have increased adiposity, insulin resistance, diabetes, metabolic risks. And Caucasians, the whites usually have a mild phenotype, and the East Asians, that is from Japan, Korea, China, have lower BMI and milder hirsutism, and Africans have higher body mass index, they're more obese, and their metabolic features are also high. So one needs to know that different ethnic groups will present differently the same polycystic ovarian syndrome. So how do we manage the polycystic ovarian syndrome? The most important is lifestyle measures. Lifestyle meaning diet, exercise, these are the main parameters. So in this, you have to maintain a healthy weight. You have to lose at least 5 to 10% of your excess weight, and that much itself will lead to significant improvement in your symptoms. Weight loss targets, we all know how frustrating it can be for us, for our patients. So something that is measured is, it has to be the smart way of losing weight. So what is smart? Specific. You have to say, you are 68, you become 62. Specific, measurable. You can measure it. Achievable. 90 kg lady, you say you come back in 60 kgs. It's not possible. Realistic and timely. Set timelines. In 1 month, in 2 months, you need to lose this. So, a smart way of losing weight is very important. Then, along with this, sometimes your assertiveness, slow eating, cognitive behavior monitoring, because the food Is this like a stimulus? You could be stress eating. So behavioral strategies need to be in place. And usually, if you are less than 500 calories for your daily dietary intake, so roughly for women, it boils down to 1200 to 1500 kilocalories is what is advised, and less of whites, like less of sugar, less of carbohydrates, more of fruit, more of vegetables, more of proteins is what is usually advised. Exercise is very important. Just dieting is not enough. And in this, if you want to lose weight, moderate intensity and vigorous intensity. Per week, moderate is 250 minutes, which is 60 minutes in stress is 4. About 4 hours in a week of moderate intensity, about 2 hours of vigorous intensity in a week, and muscle strengthening at least twice in a week. So all your groups of muscles should be strengthened, the upper body, the lower body, hands, legs. So it has to be a regimen that, a physiotherapist and a weight trainer can give the patient. So after all this, the fertility treatment, when they come to us, the management usually is first is lifestyle. We cannot just jump lifestyle and come to medicine. Lifestyle is very important. And then you have the medical management, which can be ovulation induction drugs, because these women have, they don't ovulate regularly, they have delayed cycles or early cycles. So you give medications that make the follicle mature and release the egg. It's called the ovulation induction agents. And nowadays, the first choice is letrozole. And clomiphene citrate also used to be used earlier. It is also a good drug. You can combine it with metformin, which is, again, it lowers blood sugar level, but its mode of action is an insulin sensitizer. It reduces androgen levels in PCOS and gonadotrophins. So if the oral drugs don't work, then you give injection for ovulation induction. And then you could go into laparoscopy, and then you could go to IUI or IVF. So these are the drugs which cause the egg formation. They correct the hormones. Myo-inositol is another product which will corrects the insulin, hyperinsulinism, hyperandrogenism. It corrects all the balance. Good supplement of folic acid, vitamin D, all these things we can give. And then at least I believe that young couples, maybe with associated other pelvic anomalies like maybe a tubal block, endometriosis, but even just PCO, young, laparoscopy, if you do these punctures in the ovary and the duration of infertility is less, say less than 2 years, young lady, sperm is normal. So you do this laser drilling, the androgen levels go down, the hormonal milieu improves, the automatic ovulation may start. Along with it, you wash the uterus, you wash the tubes, if there are any small clots, mucus plugs. So it's a very good fertility enhancing procedure. It takes about an hour. It's a keyhole surgery. Good option for young patients. And especially those who have not responded to medicines and do not want to go ahead with other ART methods. And then, of course, IUI is you give either the medications or you give gonadotrophins, you monitor. Of course, natural cycle trying is also good, even on a superovulated cycle. But if you time it, especially in PCOS, and wash it and inject it around the time of ovulation, the pregnancy rate with IUI in PCOS is definitely higher than natural. It can be tried in younger patients with good semen parameters or moderately low semen parameters. And then, of course, finally is the IVF. in which we, you have tried, or the age of the lady is high, there is tubal block, or there is male factor, or, all other methods are failing, or she's not responding to low dose gonadotrophins and you need to give high dose. And if you need to give high dose, you cannot do natural or IUI because of multiple pregnancy. So in them, you do the stimulation, then you take out the eggs, you do the fertilization, embryo formation, and then you transfer the embryo. Roughly, in a good center, it comes out to about 50 to 55% pregnancy rate per embryo transfer, and cumulative in 2 to 3 cycles, close to 90%, especially in young patients. So IVF is one of the last options, but is highly effective, even in women with PCOS. So PCOS needs a multidisciplinary team, lifestyle, your increased testosterone, fertility counseling, psychological support, nutritional counseling, metabolic intervention. But finally, overall, the prognosis is good if lifestyle parameters are followed well, and fertility potential and fertility prognosis is also very good. So thank you very much. If you have any questions, you can put it in our channel and we will be happy to answer. Thank you very much.